Okay, my name is Stephen or Skip Radwinny. I go by Skip. I'm going to talk about ethical issues that might arise in your work at Grace House, in your work as workers and volunteers. I've been a palliative medicine physician for 30 years, hospice and palliative medicine, and I chaired an ethics committee for 22 years. So those are my sources, I guess. So the subtitle of this talk is Never Worry Alone. We're a team in working with our residents and patients, and as a team, one should never worry alone if one thinks one's in a bind about an ethical dilemma or a moral dilemma. How do you decide what is ethically right and wrong? Now let's talk about ethics versus morality. Ethics refers to standards of good and bad, right and wrong is determined by a community. Morality refers to standards of good and bad, right and wrong that are personal. Why are ethical issues important to us? We care for those who can't care for themselves. We provide hands-on, in-person care to vulnerable people. We also form close emotional ties to our residents. And finally, we're going to be caring for people who may have been marginalized or isolated or abandoned. I think that puts a greater burden on us to do the right thing. And what is an ethical dilemma? It's a situation where there's conflict over important decisions, and that conflict may be internal, where you wonder if an action that you take conflicts with your own moral compass, or external, where different people or groups disagree about the right course of action. What types of ethical issues will be most important at Grace House? These are the things I'm going to talk about. Confidentiality, decision-making capacity, advance directives, DNR orders, nutrition and hydration, and treating pain and the double effect. Now, how do we resolve ethical dilemmas when they arise? We look for principles to help us, or a principle. A principle is a basic way of thinking, a rule that guides us in deciding if an action is right or wrong. And in medical ethics, there are 4 core principles. These are widely accepted ethical principles that we use every day in healthcare. The first and primary one is autonomy, that a patient is allowed to make their own decisions whenever possible. They control their own body. Beneficence is the second one. That has to do with doing good for patients. That seems obvious, but we always have to call on that. Non-maleficence, do no harm, protect patients from harm. This also seems obvious, but it should always be brought to mind. And finally, justice, respecting the rights of the person and/or fairness in the distribution of resources, and in our case, of healthcare resources. Did I mention never worry alone? Never worry alone. Get all the information. Try not to prejudge any situation. And this is very difficult. This can be a challenge not to prejudge because we take so much into this work ourselves and of our own beliefs, our own life experiences that might cause us to prejudge a situation. Work with the patient and others to make the best decision possible. Put the patient, our resident, first. Consider the ethical principles which might apply. Also, finally, consider benefits and burdens to the resident or patient. What is the benefits of any decision that's made? What are the burdens of that decision to the resident? That's how we must frame it. Now let's go back to talk about those individuals. First, confidentiality. A resident's personal information is their own and theirs alone. Medical or other information cannot be shared without the resident's consent. Social media have put a stress on confidentiality. People, sometimes healthcare workers and volunteers, share information on social media that they never should. The best rule is don't say anything about your work on social media because it could always come back to you And it could always, more importantly, could always come back to the patient. Now, you learn about HIPAA, and you will in your orientation, and about confidentiality and the legal restrictions around confidentiality. But first of all, this is a moral and ethical obligation to protect an individual's confidentiality. If there were no HIPAA, we would still have that moral obligation to protect an individual's confidentiality. So what are the principles that might apply? Well, autonomy, because the patient owns their own information about themselves. And non-maleficence, do no harm. Putting an individual's information, personal health information, out there does harm to them. Now let's talk about another issue, decision-making capacity. To talk about decision-making capacity, we have to talk about informed consent. To have truly informed consent, to consent to a surgery, to accept a medicine, even to accept a bath, individuals, our patients, our residents, have to have all the needed information about the treatment and fully understand it and freely give the okay to it. This is informed consent. But informed consent depends on a patient or our resident having decision-making capacity, the capacity or ability to really make a decision. And how do we decide if a person has decision-making capacity? The individual must have a basic understanding of the decision. They must understand the risks and benefits of proceeding or not. They must be able to express that understanding, and they must be able to express a choice and give some rationale for that choice. Those are the 4 requirements we think about when assessing an individual's decision-making capacity. It's also important to note that all decisions are not the same. Thus, capacity varies for an individual based on the decision they have to make. So, for a person to consent to taking a bath or being given a bath in our facility, we would set a very different standard than if they were requesting transfer to the hospital and full-bore medical interventions or surgery. See, those decisions are very different, and therefore the standards of capacity are going to be much higher for consent to surgery than for consent to taking a bath. I hope that helps. Let's contrast capacity and competency, because these are sometimes used interchangeably and they're not. The most basic way to understand this is competency is a legal determination. Capacity is a determination made at the bedside and can be made by the healthcare providers, by the doctor, the nurse practitioner, the clinical nurse specialist. Capacity can wax and wane depending on the individual's mental status, and it can be, as I said, decision specific. Competency is a determination made by a judge. It's permanent unless overturned by a judge, and it is ability specific, not decision specific. It has to do with that individual, and it carries forward unless it's overturned, that determination of competency. So remember capacity versus competency, and we will most often be talking about capacity with our residents. What's the next ethical issue we can discuss? Advanced directives. What are the types of advanced directives recognized in Ohio? There's the living will. These are wishes regarding artificial nutrition, hydration, respiration, if a person is permanently unconscious, incapacitated, and terminally ill. So that's a limited set of circumstances. People often think the living will prescribes all health care at the end of life, but a living will only applies when somebody's permanently unconscious, incapacitated, and terminally ill. Now, that being said, if a person filled out a living will and said certain things in there, that may give us some sense of their intention, even if they're not imminently dying. But Legally, it only applies in those limited set of circumstances. A healthcare power of attorney is a designate, a surrogate, a person who can make decisions for a patient if they're no longer able to. And this is determined in writing. There are forms, requires witnesses, etc. But that's a person who can help make healthcare decisions if the person is no longer able. Declaration for mental health treatment. This is also called a PAD. It indicates treatment preferences when somebody is unable to do so due to psychiatric illness. And organ donation preferences, I think that speaks for itself. Now let's contrast the durable power of attorney versus the healthcare power of attorney. The durable power of attorney is someone you designate to handle financial matters if you become incapacitated. So somebody can have a durable power of attorney but not have somebody to make healthcare decisions. Very often, that durable power of attorney might be the person they want to make their healthcare decisions, but that should be clearly established. Healthcare power of attorney is someone you designate to handle medical decisions if you become incapacitated, and this is sometimes called the durable power of attorney for healthcare. The healthcare power of attorney is a document which an individual designates a surrogate to participate in medical decisions on her behalf if she is incapacitated, to participate in medical decisions. The patient need not be terminally ill or permanently unconscious for this to apply, just unable to make their own decisions. It's relevant for all decisions, not just those regarding life-sustaining nutrition, hydration, or respiration. And then the document, the Declaration for Mental Health Treatment, the PAD. It's a document in which an individual indicates facility preferences, physician preferences, treatment preferences, or medication preferences or allergies, along with a surrogate in the event she loses capacity due to a mental health issue. Also in Ohio, there's a designated hierarchy of next of kin who can make decisions. So if a person hasn't spelled out a healthcare power of attorney, who makes those decisions? There's a specific hierarchy that is followed. And this is pretty intuitive, you'll see, as to who we go to. First, this may not be intuitive, the guardian trumps everything else. If the individual has a court-appointed guardian, that guardian takes priority in all healthcare decision-making. Now, that guardian may involve others, may involve loved ones or acquaintances to help inform them in their decision-making, but the guardian has ultimate responsibility. For all intents and purposes, according to the law, the guardian is the person. Next would be the patient's spouse. After that, the adult child of the patient or the majority of the children, if there's more than one child. After that, the patient's parents. Or next, an adult sibling or the majority of siblings if there's more than one. And next, the nearest adult related to the patient by blood or adoption. For any of these, they must be available for a decision within a reasonable amount of time, depending upon the urgency of the decision. If one needs surgery imminently, one can't wait for days to find a relative to make the decision or to help make the decision. Now that also brings us to the next point about surrogate decision making. When we talk about surrogate decision making, we should talk about their assisting with decision making, not about their making decisions. So they're really helping to advise the healthcare providers and healthcare workers about the decision. They don't just make the decision. We are always, when we work with our residents and patients, it's on us to make sure that any surrogate is acting in the individual's best interests. So the next type of ethical issue we're going to talk about are DNR orders. There are two types of DNR orders recognized in Ohio. DNR Comfort Care and DNR Comfort Care Arrest. Comfort Care is an order written by a physician, a nurse practitioner, or nurse specialist that conveys a patient's or surrogate's wishes that aggressive life-sustaining treatment be discontinued and comfort measures be implemented only. No resuscitative measures, no new resuscitative measures to be instituted, such as new IVs, ventilators, dialysis, etc. In other words, the patients decided or agreed that the focus will be on comfort and not on attempts to prolong life at all costs. And it's generally used for patients whose focus is palliative. So what does a DNR Comfort Care order entail? That we will suction, administer oxygen as needed for comfort, position, splint, or immobilize for comfort, control bleeding, provide pain medication or even antibiotics or other medicines focusing on comfort. For example, Lasix, a diuretic, is a comfort medicine in a person who has heart failure. We'll provide emotional support. We can contact other appropriate healthcare providers about the patient who are familiar with the patient, such as hospice, home health care, their primary physician, or advanced practice provider. We'll not administer chest compressions, insert an artificial airway, or provide mechanical respiratory assistance. We won't initiate new IVs to resuscitate the person or new medications to keep them alive. We won't defibrillate or cardiovert or make those attempts, and we won't initiate cardiac monitoring. DNR Comfort Care Arrest. This is an order written by a physician, nurse practitioner, or nurse specialist that conveys the patient's wishes that CPR not be attempted in the event of a cardiac or respiratory arrest, but all other forms of treatment will continue. In other words, in the event that the patient dies, their heart stops, the patient will be made comfortable. In the meantime, all or some treatment measures will remain in place. It's generally used for patients who still desire treatment, but who do not want resuscitative measures implemented in the event of death. The next topic we'll talk about is nutrition and hydration. All Grace House Akron patients will receive fluid and nutrition as they wish, but we will make every effort to accommodate every resident's specific dietary needs as well. But as death approaches, people stop eating and drinking. This is the way we were built. This is a natural part of the dying process. This is a design feature in human beings, not a design flaw, a design feature. How does stopping eating help as a person's dying? They develop what's called ketosis. This provides some sedation and comfort. It's a metabolic process that occurs when a person stops eating and drinking. There's less waste for them. There's less choking, less drooling, fewer secretions. So all of these things are protective. And this is in part, you could say, why a person's stop eating and drinking as death approaches. Some residents may come to Grace House Akron with feeding tubes due to head and neck cancer, neurologic disease. These feeds will continue until they are no longer helping or the resident no longer wants them. So you could have a tube like that in place even in a person who is comfort care. People dying of cancer, dementia, or other terminal illness are not starving to death. We should never, ever use that language. That's inappropriate. It's very loaded. It can be very distressing to individuals. Again, stopping eating and drinking is a natural part of the dying process. People are dying from a terminal, incurable illness when they stop eating and drinking in this way. And it may be challenging to accept for a friend or a loved one of someone who's been marginalized for a year and is now dying. And they may express their love by saying they're starving to death and showing great distress over this. See this as an expression of love, but it's not language we should really use. It requires some education and support when you hear that. The next issue we'll talk about, and the final one, is treating pain and the double effect. Many healthcare workers fear giving pain medicines to dying patients, thinking that they might hasten death. First, to counter this is the doctrine of double effect. This was a doctrine first promulgated by the Catholic Church, but it says that the effective treatment, harmful effect of a treatment, even if it results in death, is permissible and moral if it's not the intended effect. If you give a pain medicine with the intent of relieving pain and the patient happens to die, that's still moral because the intent is to relieve pain. As it turns out, this doctrine is less necessary than we thought decades ago. Many studies have demonstrated that when we treat pain, when we treat agitation and shortness of breath at the end of life with some of the strong medicines we use, we are actually not only making the person more comfortable, but we are prolonging life. Now think about this when you're in pain. What happens to your heart rate? Your heart rate goes way up. When you're struggling to breathe, your breathing becomes more shallow and rapid and inefficient. So if you can slow the heart rate down a little bit, slow the breathing rate down, you might actually be prolonging life. That's how these studies have demonstrated that treating pain and distress at the end of life does prolong life and not really shorten it. And finally, wanted to comment about cultural issues and ethics. People from different cultures and religions may hold different beliefs about some of these issues and about the morality of healthcare treatments, especially around fluid and nutrition, and in some cases about the importance of alertness as death approaches. It's our privilege to try to explore and better understand these differences. That's truly a privilege and things we can learn about as we go through our daily work. We have to try to honor these wherever possible and understand these. To summarize, ethics gives guidance as to what is right and wrong. Disagreements about what's moral can cause ethics dilemmas. Ethical dilemmas should be dealt with by the team because we're all part of the same team. Did I mention you should never worry alone? We are a team with our residents and patients at the center. Never worry alone. Thank you very much.